I'm Kim Varner. I am with Watercrest at Bryan. We are an independent living community. Independent living community is a next step, like I like to say, from your home. This is a place that is going to be most likely an apartment style complex. It's going to have individual apartments, so you're going to be on your own completely. No one is interfering in your day-to-day living. The apartments are fully operational, meaning your kitchen, all of your kitchen appliances are provided. You bring in your own furniture, you furnish it, decorate it how you would like. The perk of that, other than just living in an apartment complex somewhere to downsize from a home, is that most independent living communities offer things like dining services, housekeeping services, activities, transportation. I like to say when I do my tours, it's kind of like a cruise ship on land. So you're going to your room at night or during the day, but you come out. You can visit with your neighbors, your friends. You've got activities to go to, outings. You have a shuttle that'll take you places and take you to doctor's appointments or shopping, those sort of things. You also can bring your own vehicles. You can be as independent as you would be at home. Every facility that we have is going to have a maintenance department. We have a dedicated maintenance staff, and what you would do is you would call the front desk and put a work order in, and they would be there. At least in my experience, it gets taken care of within 30 minutes. So that's how it's supposed to work. Like, you're supposed to have someone there to take care of those things for you. That's part of why you're moving into those places.
Can they bring their pets?
Absolutely, you can bring your pets.
My name's Kate. I am the Community Sales Director for Sedalis Senior Living here in College Station. Kim and I will work together because residents that are currently in independent living that maybe have had a change, maybe need more assistance than what independent living can provide. We have staff 24/7 that is going to provide personal care needs or anything that you might need 24 hours a day. They love the security to know somebody is there 24/7, but most people, what they will see is that they have stopped cooking for themselves and need assistance with that for all 3 meals, or they have a care need that they cannot perform for themselves. So showering, toileting, dressing, any kind of what we call activities of daily living. We do have couples that live with us. Maybe one couple would honestly be more suited to be in independent living, but their spouse is in a different stage in their life, so they come to assisted living together so that they can stay together long term. In my particular community, we have what's called levels of care. So you might have somebody that just needs assistance with their medications. They're a lower level of care than someone that needs assistance with bathing, dressing, all of those activities of daily living. So every community will do an assessment of your needs and formulate what they call a care plan to really set out for all of their staff to know exactly what they are responsible for to do for you specifically on a day-to-day basis.
Are there things that would disqualify my loved one from being appropriate for assisted living?
Yes. So typically those things are what we call skilled nursing. So that would kind of jump you over to Devin. He'll talk here in a few minutes. But some of those things could be that you have a feeding tube, a trach, something that you truly need 24 hours skilled care assistance by typically an RN.
My name is Brooke Powell. I am the healthcare sales counselor at the Langford at College Station.
What qualifies someone for memory care?
Well, of course, a person with Alzheimer's or dementia would qualify them for our memory care. Usually this is where we see them starting to need a higher level of care than assisted living, or when someone becomes what we refer to as an elopement risk. So if we're concerned that they may leave the community on their own and not know where they're going or how to return safely, that is when we would consider memory care.
What's the difference between levels of care and all-inclusive care?
So some communities have what we call a level of care. So they're going to have a base rate that you're charged, and then depending on the amount and to the extent of assistance you need, there may be additional price that you can incur from that. In the all-inclusive rate, so it's just a flat rate that you pay per month, and it'll include the same things. One of the differences I think that's big about the levels of care versus all-inclusive is that with all-inclusive rate, most of the time there is a cap on the level of care we can provide. You want to make sure you ask those questions when you go to research.
Since memory care is such a complex situation, there has to be an assessment. Can you explain that assessment and talk about the purpose and what it may look like?
So the purpose of the assessment is to make sure that whatever need you or your loved one might need can be met at our community. Especially with Alzheimer's and dementia, there's a lot of different types. And so we want to make sure that we can meet that specific type and that level of care.
What type of staff do you have, and what are their roles that they play?
Our CNAs are going to help with the activities of daily living. So they're going to be the ones that are coming in, helping you with bathing, dressing, toileting, making sure you're ready and prepared for meals. Our CMAs are going to be administering medications. So some communities do it different. For example, ours, we do all medication management. So they're going to make sure that when you run out of your meds, that they're getting that refilled for you guys, and then making sure that your medicine is administered the right day, right time, and everything. And then the charge nurse oversees all of that. So they're primarily communicating with your PCP to make sure everything's good to go, and communicating with the staff and also pitching in when they can.
What are the staff ratio, patient to staff, typically?
So it depends. We are a type B large memory care, so it depends on your licensure. So for example, we are required at minimum to only have 2 CNAs to our 18 residents. And so it depends on the community, their size, who they have available. That being said, I mean, we are going to also have CMAs and nurses. Like, you're going to have more staff, but you always want to ask what their minimum is based off of their licensure. So the state will send out what they call a disclosure statement that will tell you that information on what is legally required at minimum.
A lot of with regular assisted living, there are some that have nursing care 24 hours a day, but it's not required. It's required that they have a nurse on staff that oversees the care that's provided and writes the care plan. So that might look like a nurse Monday through Friday, 8 to 5. That I've been one is a paperwork nurse. It's not, generally speaking, it's not one-on-one care, that nurse going around to see you or your loved one. So you got to make sure that when you're asking about nursing staffing, they might have a nurse, and the minimum might be that that building is required to have 1 nurse full-time, but they're not going to be there at 10 p.m. It might be different in memory care. It might be different per the company that you're working with. But nursing care and assisted living is not meant to be hands-on, one-on-one nursing 24 hours a day. So when you're asking those questions, make sure you understand what your own expectation is versus what is provided under that type of care.
Good morning, appreciate you being here. My name is Devin Shelby. I'm an administrator for Legacy Nursing in Bryan. Today I'm going to be talking about skilled nursing as well as long-term care. Both of these typically take place in a nursing home, but there's the skilled nursing portion and the long-term care. I just want to say that all of these folks up here represent the independent living, assisted living, memory care, and skilled care. This is home for the people that are there. So these things, from activities to outings to pets, in most of these settings, that's encouraged. So skilled nursing basically we're going to fall into 2 categories. We're going to have the therapy side, or we'll have the nursing side, or maybe both. The therapy side will be physical therapy, speech therapy, occupational therapy, thanks guys. And then on the nursing side, we'll have things from trachs to wound care to IVs, medication delivery as well. So folks can be there for either of those 2 sets, the physical therapy part, the therapy or the nursing, or both. Long-term care Can go everything from, it's basically you need help not with those skilled items, but you need more of the daily living skills. You need some help bathing, dressing, eating, these type of things that may be a little bit more intense than would be for an assisted living. So, and we will do some memory care as well. Respite care also falls into that. You can be long-term care, you can be in long-term care for one day for respite, or for 10 or 15 years, depending on what your diagnosis is. The majority of the skilled care that's paid for by Medicare or by managed care. Those two care for most of that. Those time periods, though, are usually 4 to 6 weeks is the average in skilled care. Theoretically, up to 100 days. Those 100-day packets, you can have more of those throughout your lifetime as long as you have a 60-day period of wellness in between. And that period of wellness means that you're not getting IVs, you're not getting therapy. You can still be in the nursing home, but not receiving skilled care. As long as you've got a 60-day period of wellness, you'll be eligible again for another 100 days of the skilled care. For the long-term care, Medicare and managed care don't pay for the long term. So that typically is where the private pay comes involved, or in Medicaid if the private funding is not there.
Explain the difference between your inpatient rehab and regular inpatient rehab.
Good. So the inpatient rehab, and this is like in a hospital setting or even at Encompass, which is tied to the hospital. Those folks, they have a higher threshold. They can actually do more therapy. They'll get more hours there. They'll get the same type of therapy for the most part. It's just their endurance and their ability to handle it is more. So sometimes folks will come from a hospital to the nursing home to get built up to where they can get inpatient care, go over and get stronger and go over and be able to do more hours in the inpatient care. Sometimes it works the opposite way. Folks don't quite make it in the inpatient care, so they'll come down and step down to our level and do the therapy with us.
So that kind of answers this. So if I leave the hospital, go to inpatient rehab, am I still eligible to come to you at a SNF?
Yes, absolutely. So you can, the idea is that these services are available to you no matter where you're coming from. If you can come from a hospital to a skilled nursing facility, you can go from inpatient to a skilled nursing facility or back and forth either way. When you're discharged successfully, hopefully, from the skilled nursing facility, within 30 days, you can come straight back to the nursing home without having to have another hospital stay.
I am Donna Williams, and I work for Cetera Health. I can go into Kim's place and I can provide services because they are skilled nursing services. I can go into Kate's place, assisted living, and I can provide services. I cannot go in Devin's place because your skilled nursing is already presented there. You contact a home health agency. There are many in town. Sometimes you may get a referral if you're in the hospital. Your doctor may refer you, or if you're just out in the community and they're saying, hey, I'm having issues with this and I'm having issues with that. We can help you with that.
Are all home health companies the same, or do I have a choice?
You always have a choice. Sometimes when you're in the hospital, they bring in this list for you to choose from, but it's always your choice, and you always have the option to choose whatever home health you want. Some home healths differ. They may not service the area where you live. There may be a discipline they do not have. Your insurance is a big one. Not all home healths take all the same insurances. A certification period is a time that you are certified to be on home health that your doctor has signed orders for, and it's usually 90 days. We can't just come in there and say we're doing this and that and not have a reason to be in there. There has to be a documented reason that we're in there. So, normally if something else occurs while we're in there, or we just haven't met the goal of why we originally went in there, then, the time frame differs for the amount of time allotted on home health. On home health, you cannot be running around town at the mall, flying off to Vegas. You have to be sick and you have to be somewhat homebound. That doesn't mean you can't go to the grocery store. It doesn't mean you can't go to the senior center, but you do have to be somewhat incapacitated. Sometimes you may get discharged, taken off services because you're doing good, and then all of a sudden something else may flare up, or that issue may come back again, and you may come back on services. Claudia is non-medical, which is a type of care you get in your home. We are home health. We are covered by Medicare, and we are skilled on the medical side. People sometimes get us mixed up with, well, I want somebody to come in, and I want them to cook, and I want them to clean, and I need to go to the hairdressers on Thursday mornings at 10. That is not us.
My name is Claudia Massey. I'm with Visiting Angels Home Care Services. The biggest difference in everything that you've heard is that we are non-medical. So for instance, Donna was talking about home health. There is a nurse coming out. There is a therapist coming out. With home care, we can have either students, they are trained on our services, all the way to CNAs, certified nurse aides, and they can have a particular type of training to help your loved ones at home. There is home care that is covered provider care services. You have to qualify through Health and Human Services, and it may be covered with a provider. As far as long-term care insurance, that does cover home care. And if you call any of the agencies here in town, they can walk you through what long-term care looks like. There are thresholds. Sometimes we get calls, is it too early to start a claim on my long-term care? Is it too late? Long-term care is definitely something you want to get as much information about as possible, so you know when to tap into it, so that you can maximize your benefit, because if you don't use it, you lose it. Veterans are entitled through their pension or through their disability to receive homemaker and respite services. Sometimes we have veterans that come to us and they ask for services, but they have to go through their VA, and it's a lengthy process. I would say 3 to 6 months for it to come through. So we do work with the BVCOG, the Area Agency on Aging, and we might ask them and give them a referral so that we can start helping that veteran at home until those services kick in. And respite is very different from homemaker. Homemaker services helps with personal care, one-on-one care, meal preparation, light housekeeping, transportation at times, just helping you get in and out and around your home. Respite is more of a relief. So say for instance, Donna needs help with her aunt. She has to work, but she needs someone to kind of check in on her aunt. And so we are going to provide respite services for her aunt so that Donna can continue to work and sustain the household.
Are there any other home care benefits for veterans other than the respite in the home that you mentioned earlier?
Yes, and I feel like aid and attendance is something that is, I think, probably one of the underutilized benefits. It is a simple referral. You can call any of the home care agencies. They walk you through that referral process. That process should not take more than 60 days max. So here's the scenario. If he qualifies and they say, yes, you qualify for aid and attendance, the company that is working with him will say, we're gonna go ahead and allot 40, I'm gonna give you an example, 48 hours of care a month. And your brother can decide, okay, I'd like to use that a couple of hours every day. I'd like to use that 4 hours 3 times a week, and I want help showering, bathing, transportation, whatever the case may be. Or I might use that for an entire weekend.
Some aid and attendance too can help assist with paying for assisted living as well. So it can pay for homemaker services, but it also can help pay offset costs for assisted living.
I'm Risa Meyer. I am with Caring Transitions and Miles of Grace Realty, so I kind of have 2 hats today. When thinking about downsizing, this could look like you're moving into, one of the levels of care, different communities that have already been discussed. It might be looking like you're moving to, a family's house. You're just changing your living situation. It may just be figuring out how to make your home work for your current needs. Looking at providers that are going to help with the items in your home. That is obviously a vulnerable place where, you know, all of these providers are coming into your home. So really, it's good questions for everybody of just asking, you know, for references, are they insured? Asking specifically for their expertise in working with seniors, because some providers are just going to be more sensitive to the downsizing needs versus, you know, moving somebody out of, you know, one of the college complexes across the road. That's just a different level of service and a different population. So just asking questions, asking, you know, your friends and other people who they've used for different services. It's a complicated answer, and it is different for everybody. When you think about downsizing, often you are going to be using less of the items in your home or getting rid of items. And, you know, our company specifically helps with selling items. Sometimes selling those items can help pay for other services that you might need. There is value in selling items, but a lot of times the value is in your home. And so getting it cleared so you can move on to your next phase is the higher priority. And so donating those items might be a better solution for your time frame. There are things that sell better than others. Tools, lawn equipment, things that don't go out of style are always, there are buyers for those things. And so, you know, but when you're talking about glassware, furniture, some of the things that just aren't being used as much now in people's homes, those may be better items to donate. But yes, we can help you with those decisions as well.
Good.
As you're considering your options now and in the future, just calculating those costs of what, you know, what your current situation requires and what those, you know, future needs might require. So specifically with the home, there's a lot of costs that go with that, even if it's paid off. You know, there's the taxes and the maintenance. Those are the expenses that are financial, but also emotional and stressful. And, you know, sometimes getting into a lower maintenance home situation, whether that's an independent living community or, you know, just a patio home that doesn't have a huge yard, or sometimes taking those moves earlier than later is better. You know, making those decisions for yourself before you know, a life change forces those decisions. What would you call your home? Would it be a place of peace and rest and you have what you need and it's not too much to handle? Are you able to access the things that you need in their home? Are things where they need to be on a lower shelf so you're not having to climb on a ladder to get stuff? Are things up in the attic that you're needing? If you are, you know, constantly just worried about certain parts of your home, there may be somebody to call to help with some of that, but it may be time to start looking at other options as well. You know, I think home maintenance can get out of hand really quickly, and that's going to hurt when you go to sell your home because any deferred maintenance is going to cost more later.
Hi, I'm Rhonda Stevens with Medicare Equipment Specialties, and we specialize in home medical equipment.
I'm going to shorten that to DME. So durable medical equipment is DME. So how does one qualify for DME?
You start with a visit with your doctor, discussing the need for whatever, if you're trying to get a walker, a hospital bed, or a wheelchair, you have to go see your doctor and talk about those things that you need in the home. Especially what we see a lot on wheelchairs, if you go to the doctor and you're trying to get a wheelchair and you say, I just need it so when I go to the grocery store or I need to go shopping, Medicare is not going to pay for it for those reasons. It has to be what you need to be able to move around the residence of your home.
What are the Medicare guidelines for DME?
So again, Medicare is going to require a face-to-face visit with your doctor within 6 months of the written order. So he's going to have to talk about maybe you were, you know, at home, you're needing a hospital bed, but you're not able to lay flat in your bed anymore. You've tried wedges, pillows, side rails, none of that's helping you. So then you would be able to, he would order a hospital bed that says that you need that. And I always tell people, if you go to the doctor today and you have an appointment with your doctor and he's gonna order this, you probably won't get the equipment that day. Medicare requires that when DMEs are going to bill for equipment, they have to have those notes from your visit discussing the medical need for it. They have to go in depth about why you need that bed, why you can't sleep in an ordinary bed. All your big stuff as far as, again, wheelchairs, beds, oxygen, trapeze bars, patient lifts, those are always just going to be a rental. Medicare only rents those. They rent them for you for 13 months and then the ownership goes to you. Now, in those 13 months, say something happened, you no longer needed it, maybe you went into skilled nursing, then that equipment goes back to your DME provider, because Medicare is not gonna pay while you're in skilled facility or in a nursing home. Now, your walkers, your canes, your small, what they consider inexpensive, routinely purchased items, those can be done as an outright sale. You don't have to rent those. You can if you choose. Say you only needed it for a month, then you would be able to rent it for that 1 month and then just return it. But if you're gonna need it long-term, then those items would be a purchase.
Hi, I am Melissa Bergeron. I am Director of Operations for Mirror Care Consultants, and I'm speaking to you today about senior care management.
What qualifies someone for senior care management?
Any aging adult, anyone that's facing healthcare challenges actually can reach out to a senior care manager. Senior care management, it was also called geriatric care management, and there is care managers all across the United States. So we provide a holistic approach into helping you navigate through the healthcare system. So we partner with all of these agencies just to make sure that your loved one is getting the proper care that they're needing, whether the wishes are to stay at home, whether it's an independent living, to come home from a hospital, to enjoy their last stages of life. It is a private pay source. There are some long-term care insurance policies, some of the older ones that do have a care management component in that. So it's just a matter of calling your insurance agent provider and finding out what all those benefits are. So there is a piece, but we charge per hour, but not all of our activity is hourly. So we can charge in 15-minute increments. So based on how involved you want us to be with you or uninvolved, we can just do an initial care plan, provide you with all the recommendations, and then you can say, okay, I can take this, and now I know where I need to go, or we can help with you step by step throughout the way. A hospital case manager is going to focus on the task at hand. So it's to discharge home safely. It could be a quick kind of approach too. We all know we get that phone call, oh, you're ready for discharge this afternoon at 5 o'clock. So we partner with a hospital caseworker just to make sure, is home health set up already? Do they have the equipment? Are they needing hospice? Is it, should the recommendation go to a skilled nursing or an inpatient rehab? So we will help and work with the family and the hospital caseworker just to make sure that everything is in place. The biggest difference is then we get to be home and make sure that all of those resources are then implemented, because we all know we get home and we may forget to pick up a medication. We don't remember if we're supposed to follow up with the doctor. So then your aging life care manager is making sure all of those steps are followed through.
My name's Kobe Boykin. I'm also here as part of our APS volunteer board. I'm going to talk to you guys about hospice in general. It is an insurance-based benefit, so there's hospice coverage for virtually every insurance out there, whether it's a managed care plan or it's a commercial plan for people still of working age. Medicare covers hospice at 100%, so does Medicaid. There are also options for people that are not funded by insurance. There are, I can't see all of you, but there's lots of hospice representation in the room today, and we all work together to find hospice care, even for those that do not have insurance to pay for it. If it's Medicare, usually any version of Medicare, whether it's your managed plans or traditional, will cover hospice at 100%. That means no bill to you or your loved one. Same with Medicaid, 100% covered. The commercial insurance plans, every plan's going to be different. It's going to depend on what your coverage is. I think most hospice companies will run those benefits for you first, so there's no surprises later. The thing that I hate the most that the general public knows about is the 6-month prognosis. Everyone's heard of that before. I've got to only be alive for 6 more months to qualify for hospice. That's scary, huh? All that means is that if the disease process that you have were to continue the way that it is now without anything to check it up or interrupt it, that it wouldn't be all that surprising if in 6 months you weren't with us anymore. That doesn't mean that if 6 months passes and you're still with us that you can't still receive services. You can. I've been where I'm at for 2.5 years now, and there's patients on service that have been here longer than I have. So that's really just a reference that has to be in place for insurance guidelines. As long as you continue to meet that medical criteria and you want to be on hospice and you agree with that philosophy, you can remain.
Can I still take my medication if I'm on hospice?
Yes, we hope you do. The only medications that you can't continue to take are those that are considered to be aggressive or curative. So that would be things like your oral chemo. You'd still be receiving chemo in some way. Those types of medications that are considered ones that are actively or aggressively treating the underlying condition. The goal is comfort and symptom management, so you'll be receiving a multitude of medications to keep those symptoms under control.
Do I have to go to a nursing home or a hospice facility to be on hospice?
No, but you can if you want to. The great thing about hospice is that hospice can take care of you or your loved one anywhere that you call home. So everyone that spoke before me, your independent living, your assisted living, your memory care, your long-term care, we can provide care in all of those places. We can provide care in the home. There's a level of care of hospice that can be provided during a hospital stay. The only overlap that we can't have is part of what Devin does in the skilled nursing side of things. If you're receiving skilled care, your insurance isn't going to pay for skilled nursing care in a nursing home and hospice on top of that. You would complete your skilled stay first, and then when you went back to the long-term side of things or back home, then hospice would take over. There's one really big difference with palliative and hospice care. All hospice is palliative because palliative just means that we're making you comfortable. With true palliative care, you can still seek aggressive treatment. You can still go in and have chemo or radiation. You can still go to see any specialist. There's no overlap with doctors' offices or anything like that. Generally, there's a little less in-person care from the hospice company when you're on palliative care. But with true hospice, you would not still seek those aggressive treatment options, and you wouldn't still be going to the hospital when something came up. You'd be referring to your hospice team for that.
I'm actually representing two companies, Stearns Design Build and Stearns Home Care. Both serve the elder community. So the home care, we're not taking care of people in the home, we're taking care of the home. It's a subscription service, and we come in every 2 months, and through the course of a year we will have taken care of and looked at pretty much everything in the home so that it doesn't deteriorate. So what happens very frequently is we can no longer get on the ladder, we're not cleaning the gutters, we're not seeing as well, and things just begin to deteriorate in the home, and that's often what has people leave their home. And sometimes you need a bigger project done for aging in place, such as an accessible bathroom or kitchen accessibility things, and Stearns Design Build can take care of that.
How much space is needed between furniture for walkers and wheelchairs?
That's a good question. As much as possible is the right answer.
Okay.
However, there's a more specific answer, and to go through a doorway, ADA says you can be pretty limited. But when we're talking about the walkways in your home, you really want to be more expansive than that. Tripping and falling is one of the leading ways that people get hurt and can't stay in the home. So we want to make those walkways as wide as we can. And if you kind of squeeze it in there and you think it's okay, then somebody comes over and they adjust it, they're cleaning the home maybe, and it's a little bit further, and then you trip over that. So we're always, in our assessments of a home, we're always making sure that we're getting those pathways as wide as possible.
So talk about the assessment of a home. Do you go around and kind of identify areas of where bars are needed and things like that?
We can do that. Now, we are not an occupational therapist, and
okay.
So if you can get an occupational therapist, that's great, but we're certified for aging in place modifications, so we can do an awful lot of that assessment. Our home care, we're through that process, we're doing things like cleaning the gutters and taking care of the various things in the home, and we're also doing things like looking at your roof to make sure that it doesn't need to be replaced, or that it's got an area that we can repair, that we will. We're looking at siding to make sure that there's no rot starting, because that's the things that, as was mentioned before, will really depreciate your home. What we're going to do is we're going to walk through the home. We're going to look at everything that has to do with that. A big one is lighting, for example. At 65, we need 4 times more light to see equally to somebody who's 25. So lighting is a huge thing. Spaces between rugs that can be tripped over, where there needs to be grab bars, where there needs to be ramps, where things that you have to step over can be lowered. So we're looking at a whole range of things.
What are some of the best strategies for cutting utility costs?
Oh.
I'm
blasted. I need 3 hours. So the 2 big things on utility costs are air inflow and insulation. The easy one to take care of is air inflow. So weather stripping on doors is huge. Caulking around plumbing penetrations and electrical penetrations. There's an awful lot that can be done to lower your utility cost just by doing some things that actually you can probably do yourself. So most homes in our area, our standard of construction isn't that great. So most homes leak like a sieve, and most homes also don't have adequate insulation in the right places. So to do that assessment, we put a blower door on the house, we depressurize the house, so we can walk around and see where air is coming in, and also we use a thermal camera to see where insulation is compromised.